I'm Dr. Karen DeSalvo, and I'm the immediate past president of the Society of General Internal Medicine, and I'm right now serving as the Chief Health Officer at Google Health. Across the journey of my career, I learned definitely from my patients that there were a number of social and personal factors that were driving not only their ability to engage in the care plan, to stay well or to get well, but frankly just affecting their life outside of the tools I had in my toolbox as a doctor to help them. I think all this really came to a head for me at the time of Hurricane Katrina in New Orleans, when in a very short period of time, the social determinants of health were dramatically impacted for our entire region because the storm wiped out schools and libraries and faith-based institutions and jobs and impacted the environment. I mean, you could go on and on. I think for me as a doctor, really drove me to want to do more to support the context in which people's health was happening, in addition to being able to address their health.
Social determinants are important in general medicine and in healthcare because as a physician, I am quite humbled by the task that I have of prolonging healthy lives when I can and relieving suffering when I cannot. And I know I have maybe 20 or 30 minutes with a patient 2, 3, 4 times a year to do that task. And the truth is that the majority of what explains people's health outcomes is not what I do. It's their genes that they're born with. It's the family and the environment that they grow up in, where they live, work, and play, and their health behaviors. And physicians need to broaden their scope. They need to look up from the patient that they're sitting from, look up from the screen, and embrace the fuller set of determinants in people's lives that shape their health outcomes.
The social determinants of health are the conditions in which people live and learn and work and play that have a material impact on the health of individuals, but also of populations. This is big, as it sounds. It's a mix of things like economic opportunity, educational experiences and opportunities for quality education, plus things like environmental exposures, public safety and air quality. And then, of course, a mix of things that are much more personally related, like exposure to things like racism or access to quality housing or a safe place to lay your head at night. This has been known in the public health community for generations that these big, broad factors are a huge driver of health outcomes. As much as 80% of people's health outcomes are related to these social determinants of health, and only about 20% to medical conditions.
So the process of writing the position statement started with Karen DeSalvo, who was the president of the society last year, under the purview of her theme for the presidency, which was understanding and incorporating social determinants of health for the general internists. And so she had asked me if I would be willing to chair the work group to write the position statement as an impetus for essentially a call to action for all general internists to understand social determinants of health and to understand how best to include it in the work we do across the spectrum of all the jobs that internists undertake on a daily basis.
As a sociologist, I particularly was also interested in framing this piece in a historical perspective and how historical injustices such as redlining, as we talked about in the paper, create direct and indirect health disparities. And this sort of focuses on the ethical imperative and, in fact, the human rights imperative that we have to act on social justice issues, because what underlies these social determinants of health are previous injustices, and so there's an ethical imperative for us to work on this area. And so I think that overlying or having ethics be the framework which we think about the whole paper, I think both creates the force and the impetus for why this is important.
So the work group involved members representing all the committees and commissions and the SGIM Council. We had representatives from SGIM Council, from the Health Policy Committee, from the Health Equity Commission, from the Clinical Practice Committee, from the Research Committee, from the Academic Hospitalist Commission, from the Education Committee, and from the Women in Medicine Committee. So bringing together all of those bright minds, understanding that how social determinants of health has impact across all the work we do as internists, including each of the representatives from the committees and commissions to bring their input and expertise as to how social determinants of health are uniquely reflected in the areas in which they work. In writing this position statement, we had a couple of specific points in mind that we wanted to accomplish. First, we wanted to draw the line between upstream social determinants of health. And so, as many of my colleagues understand, upstream social determinants of health are really the environments and structures in which we live and work and grow and age. And so these are related to things that seem really large and really immovable. Things like policy, things like neighborhoods, things like social structure, things like hierarchy, things like access. And we wanted to draw direct lines between these very large concepts of social determinants of health into individual experiences that general internists could draw on. So we wanted to create kind of familiar engagement points so that general internists could see these large immovable forces, but understand in a day-to-day way how they impacted patients, how they impacted communities, and how the social determinants directly lead to health inequities. The other thing is knowing that there were other position statements out there and how complex the idea of weaving social issues and medical issues can be. We wanted to make sure that it wasn't just a restatement saying that poverty causes inequalities and that it wasn't just a universal statement that had no particular action point. We wanted to drill down on what could be done and focus on how that there were all different leverage points to access rather than just speaking in grandiose terms.
So I think the position paper is a call to arms to all physicians, not just general internists, because there's as I started with this, there's a limit to the impact that we can have on improving the population's health through medical work alone, and we need to embrace the larger causes of suffering and disease, which relate to the environments we live in, the places that we work, live, and play, the healthiness, if you will, of our communities. And as physicians, we are trusted brokers, and we have, and particularly general internists, are trusted experts and advocates within the communities, and our words matter. And we need to speak up in our practices, in our hospitals, in our communities, in our cities and towns, and advocate for healthier food options, healthier transportation options, more safe places to walk and exercise, alternative energy supplies that will decrease air pollution. There's a long list, and it's a career's worth of effort ahead of us. But I think these are vital components of what we need to increasingly think about as general internists to increase the impact we can have on people's lives.
The statement and the expectations coming out of that group and what was approved by the council far surpassed what I could have anticipated. I think there's a boldness to the statement of being clear that not only is health more than healthcare, but this is the social determinants of health and their adverse impacts on some people and communities is related to generations of institutional racism and redlining. And so there's an underpinning here of structural change that has to happen. And so not only is it ethically relevant for us to address the social determinants of health because of our role as physicians, this became a very clear part of the statement and some really thoughtful work by our ethics teams. There needs to be a longitudinal educational experience as physicians enter not only undergraduate but graduate medical education, and that educational group now has an opportunity to build out curricula that become woven into the experience of every physician in training, but also become part of our competency expectations. And then what I hope the society will be able to do more of is weave the social determinants of health into all of our policy work that we do, especially in partnership with others. And this is already happened as a result of the policy statement. We've been able in this time of COVID to stand up with others and talk about the importance of funding for public health, which which is one of the recommendations that we make in the report. So I see this as coming out of this position statement. It's a call to action for individuals in their daily work in the society. It's a call to action for how we build the next generation of physicians and do that in partnership with others, but also a way that we begin to change the context and the institutional environment that really is one that drives more equity for everyone and does it in a way that really creates opportunity for health for all communities.
When we talk about health in all policies, that's not a brand new idea. It's one that's been around for a while that still has not been fully actualized or implemented. And the notion is when you're thinking about any public policy, whether it's transportation or education or housing or environment, there are health consequences to all that. Now during the coronavirus pandemic, it's more obvious than ever that the environments we live in, the density of the population, the transportation avenues that we use, the subways, the buses, it all has an impact on health. And so looking into the future, SGI, the Society of General Internal Medicine, believes that any new policy should explore what the health consequences of the public policy are to ensure that we're balancing the goals of the policy itself with any potential challenges that it could lead to in terms of the public's health.
So I think in terms of advocating for patients, communities, and institutions as a whole, it's important to go back to the issue of partnering with and humbly learning from other groups. And so I know that in medicine, throughout the history of medicine, there's always been a tendency to medicalize things. So medicalization means taking non-medical issues and defining them and treating them as a medical problem. And I think that while it's admirable that medical institutions and organizations want to sort of take up issues that are outside medicine, such as food insecurity, housing, homelessness issues, and that sort of thing, it's important to think that to remember that we want to do it in partnership with communities, that we want to engage with community partners and with experts in these issues who know more about these issues than, say, physicians. And one of the things that we noted in some of the writing that we've done around this in the commentary and the work group position paper is that, for example, if we say tie things like housing or food to medical issues through insurance, for example, what implications would that have? Let's say the person loses their insurance. Would that mean that they would lose their housing too? Or would they be afraid to maybe shift jobs because that would also influence their housing? And so I think disaggregating it is also really important. So I think it goes back to the point that we really need to partner with organizations in the community.
One of the partner reports that we point to in the Society of General Internal Medicine SDOH position statement is a National Academy of Medicine report that talked about integrating the social care into the delivery of healthcare. I had the chance to sit on that committee. We outlined sort of 5 A's that are ways that physicians can think about concretely structuring SDOH into clinical practice. The first is just to be aware that there are social drivers affecting people's health. The second is to really assess what those needs are, whether that's through structured questions that you might ask your patient or ways that use secondary data to look at the health of your community. The next A is assist. If somebody has a need, for example, around food insecurity, to assist them by getting them enrolled in programs for assistance like WIC or SNAP, and or identifying resources like a local food bank. The fourth area is moving into the space where I think our position statement begins to call out more strongly the expectation that general internal medicine participate in aligning community resources where there's an opportunity to convene and help weave together resources around the food system or transportation. This is partnering outside of our own healthcare systems. And the fifth A is one also where the society, I anticipate, will want to lean in more, which is around advocacy. So not just trying to bring together the existing resources, but advocate for changes in the systems that can drive more equity, particularly around addressing some of the social determinants of health. So advocating, for example, for better funding for the social care infrastructure or for access to affordable quality housing in our communities.
So as general internists, we get to bear witness to our patients' lives. We get to see them more than once throughout the course of their lives as we diagnose illness, as we treat illness, as we celebrate successes and hold their hands through failures. And in doing so, we're able to see the interplay of complex social and medical problems and how it leads to unequal health across the socioeconomic spectrum. Because of this, we cannot stay silent. We are advocates. We don't have to all advocate in the same way, but rather our position statement speaks in different ways that individual general internists can be advocates. We can advocate for our patients, we can advocate for their communities, and we can even advocate for large-scale policy change at the local and federal level.